So we will go on to the next speaker, which is Dr. Francesco, who always gives a great talk on simulation. So, we do all this amazing work in the operating room, but we have to teach our trainees and sometimes even ourselves get better before we do these surgeries in patients. So, Dr. Francesco.
Yes, one moment that I share my desktop. Okay, you see my monitor, my presentation is correct? Okay, thank you very much for the kind presentation, and thank you very much to Mehmet for this opportunity to combine the activity of our two committee. We have seen in the previous talk the role of the new technology in operating room, so how the navigation, how the augmented reality can help us to better understand the anatomy in difficult cases in order how to manage. But before to reach this level, we have to think how to have an effective way to learn our work. We know that the surgery is a matter of knowledge, competence, performance, and action. And the way that we reach all these competence define and how fast we reach it, define our learning curve. And in surgery, we must advise a steep learning curve, that it means a few repetition to reach the goal and to reach the our standard. But how we can define the teaching program? We know that for surgery right now, the courses and cadaver labs represent the gold standard, and there are several opportunities right now worldwide. Yeah, some example is the last that we did in Cape Town during the WFNS Congress. And we know from the literature that the experience of the participant with cadaver lab that is increase the operative skill, the anatomy knowledge, and the technical performance. But we know that cadaver lab do not provide operating specific pathology, have some high maintenance costs. The quality of the cadaver sometimes is not so good, and in some countries there is also some ethical implication that we have to keep in mind. In order to reach a good experience, we can learn during the surgery or with the courses. But sometimes when we end the program, the residency program, we know the theory, but when we pass to perform, we have some troubles, and sometimes it's very difficult to understand. So what is the real way to perform and to have a good learning curve? What is ethical and what is safe during our daily practice? That is the real question. So for answer this question, can the technology help us in this program? We know that right now the imaging evolution, the real-time navigation, the use of robots, augmented reality help during the surgery, and we have seen really fantastic cases by the other authors before me that help the surgeon to better understand anatomy, and this is essential. But some companies develop also some simulations, some models. There are simulators that can help in the teaching program. We know that the augmented reality and simulation have changed the way in other fields. I'm thinking about the military, the aviation, because simulator also the sportive driver that use simulation in order to repeat and repeat the performance and to reach the potency of the work. And the correlation between neurosurgery and, for instance, aviation and the training for the pilots is not new. Now there is a new program in Besta Institute that is called Heart-Net, because it's compare the teaching program of the Heart-Net with the neurosurgery. So it's something that it's changing over the years, and it's work. And the interest in the literature, if we found the word simulation and neurosurgery, we see that in the last 15 years, there is a high increase of publication regarding these topics. And the connection between simulation and neurosurgery is not new, probably due to the particular issue of our task in brain surgery to understand the three-dimensionality and the function of the brain and of the spinal cord. So is something that is in our specialty is really there is a kind of connection. And right now, this is a very new review of the literature, and we know that the role of simulator of the models in the training program is more and more accepted. But what are the simulations right now available on the market? We have different kinds of simulator. Maybe someone is based on a computer or using with the iPhone or with the pad that simulate the anatomy. We can perform the different steps of the surgery, but we have the completely lack of the haptic feedback for the surgical and the skill steps. The models provide a specific anatomy, so we can reproduce in a lab, so we don't need a wet lab, but we can work also in a room with the specific tools that help us. Yeah, a very short video for a posterior cervical laminectomy. You can see that I'm working in a lab, and we can reproduce with this model with a pretty high good quality the surgical intervention. So this model helps to, sorry, I can skip the video right now just to be in time. But probably the connection and the future will be introduce the virtual reality and the augmented reality also in the teaching program in order that we have a full immersive experience of the operating room and to simulate the surgical procedure. And the goal is to create the opportunities to have the feedback haptic of the singular steps and to do and redo every time we need the surgical intervention. So we know that with the reality, we have the mental training. With the augmented reality, there is a hybrid training. And then with the models, we have the haptic and manual experience. I can show some studies that are running right now. This is one that Corina with also with Harvard University with I speak with her. They develop in order to standardize the program for the anterior cervical surgery. They define a way to teach to all the residents. So an introductory video. To perform the technical notes and then to perform the surgical steps. So every resident have a model so they can repeat more times the surgical approach. So they are in a lab, in a room, and there is a tutor that follow them, and then they analyze the results. Here the results 21 residents from the two universities, and very quick all the time, all the experience and the feeling of the resident were recorded, and finally the resident that participated to these studies defined that there is a better knowledge of the anatomy in the post-training that is statistically significant, and also the timing of each singular procedure were better in the time. So we know that repetition is good. This is our study that we are running out right now in University of Milan in Vesta Institute, where we compare different way of reproduce a surgical step with a simulator, with spine models, and then the last step with the cadaver lab. And we are studying the different group. We divide the residents in 3 groups, one that will receive all the 3 different steps, one that will receive the models and only cadaver lab, and one that is the classical way of teach. This is the objective is to try to understand how the simulator and the models can affect the teaching program, because right now we know that are useful, but the real impact of this tools is not very clear. Every people receive a short video showing the lecture and the demonstration on how it works. This is augmented velocity, just to show how it works and how must be performed the procedure. All participants receive the same lesson at the beginning. Then we analyze the results of accuracy, timing, and number of X-ray scan. And we also analyze with an MNG registration the muscular activation from the beginner, from the resident, and from expert surgeon in order to weigh how the repetition can change the muscular fatigue during this procedure. Yeah, an example. I am always the first to perform this experiment because I tried by myself. And here the result we show with the simulator, so is the step 1 of the study, that with almost six repetition, the resident reach a plateau with better results. Then regarding the X-ray, the number of X-ray, again, we define the plateau in order to define how many repetitions are necessary to standardize the number of control. And we analyze of the data according to the experience with the year of residency, with the previous experience on a simulator, on cadaver lab, or in a surgical operating room, and also in gaming, because I'm thinking that the people with work and who have a very experience in gaming probably are faster in to understand the use of these tools, and this is correct. Now, regarding the muscular activation, we show that a novice have a less satisfied and with a more muscular implication, so there is more fatigue and the movement are less precise. With the trainer, we see some differences, and with the expert, we see that the activation is very selected for the muscular that we need. And again, for the expert surgeon, the use of dominant hand and non-dominant hand remain essential in order that with the non-dominant hands, it's helped the dominant hands during the procedure. So it's very interesting, and but it's just at the beginning. And now is under review, so in the future we will see the result. But what is the reality all around the world regarding the training program? I found this very interesting paper that is based on US, where there was a survey regarding the role of the simulator of models, and finally the director showed that the role in the future in for simulation and physical models will be represent almost the 80% of the activity in the training program. So is a new technology. We start to have some different kinds of tools, and probably will be adopted more and more in the different university. In conclusion, I think that simulation and a three-dimensional model are very interesting, promising tool in the training program in spine surgery, but not only, obviously. But I think that we have to think like society to better standardize this teaching program in order to have a more uniform education worldwide, especially if these tools can be reach a good cost effectiveness. So some studies to define their real implication in worldwide are essential. So thank you very much for your attention. And if there is some question, I will be happy to answer.
Thank you so much, Dr. Francesco. Amazing work as always. I really like to see this EMG results and the stress and so on that goes on with surgery and the difference between the different training. I'll open it up to any questions on the chat or
the EMG study is very interesting because we know that I was going to your comment that is really interesting. The MG study, we are just analyzing the first step. We are just working on the second setup with the different models, and is quite interesting to see how it change over the time, not only in timing of procedure and accuracy for the keyword, but also in the fatigue of the resident. And is interesting.
Yeah, Dr. Salman is asking about the cost, and that was
Oh,
also
Salman, yeah, I saw, yeah. Right now, for the simulator,
It's too much.
yeah,
Yeah. So how can we bring it down?
it's
Like,
too much. Yeah, right now some models are.
Sorry, go on.
Yeah, I know that some companies try to find the different material in order to reduce the cost, because right now the cost of a model is cheaper than a cadaver lab, but is too expensive to use worldwide in all scenarios. Little bit better is the simulator, the one that I show for the keywire, have an initial cost, but you can use infinite ways and infinite times. So you have only an initial cost, but finally you can use year by years, and really there is some residents that perform the different difficulties 100, 200 of times because was there. So when it was free, he start using, and is really his feedback change over the time. For the models, obviously are the best future, because we can probably in the future we can consider also to have anatomy specific or pathology specific models, but as you explained, the costs right now are pretty high to be usable for all the centers.
Okay, great. I think